Hello.
Good morning.
Good morning.
I'm fine. How are you?
What's about the rest of students? Do you have any ideas whether they are coming or not?
I will send them now the link.
Okay. Maybe I'll send my invitation again. Have you already studied the acute rheumatic fever at your practical classes? Acute rheumatic fever, infection endocarditis. Did you study this
No,
already?
no.
Not yet. Okay. what questions do you have at the moment regarding the topic? Our today's main topic is acute rheumatic fever, and probably if we be in time, we'll also discuss infection and endocarditis. For instance, I lost the idea. I had some idea to tell. So I'll send the link to the presentation you'll have. Not edit, but okay. Station. I will find your joint email. Copy email address. Good. Okay. Okay. I hope we can start already. I'll make a photo shot or screenshot of who is present now at the moment. And could you please inform the rest of the students to about the fact that we have already started our lecture, okay? And I've sent the email to you with both invitation and links to the feedback form or register form and link to the presentation as well. I'll make a copy to our chat now. Oh, lecture. Here it is. Okay, you have these links in your chat now as well. And please don't forget to register in the in the feedback form. Okay. Okay. So, do we have any ideas about the rest of the students? Why not coming? Hello, are you there?
Doctor, they're in Georgia.
Pardon? Could you repeat, please?
They applied for the mobility program, so they're in Georgia.
Oh, really?
But I think that the lectures are online for both online and offline students, right?
Mm-hmm.
Okay, I don't know that.
Okay. Okay. So anyway, let's go. Let me find the presentation. So again, I'm happy to meet you today at the 17th of October 2022 at our next lecture in the course of internal medicine for dentists, for dental students, so students who are specialized in stomatology. And this lecture is going to be dedicated to acute rheumatic fever. My name is Alexey Kalmykov. I'm professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University. If you have any questions, feel free to ask them in the chat, or if they are urgent, just orally. Do you see the presentation, for instance? Do you see it? Okay. Okay. Thank you. So the definition of this term, of this disease, is so there are, for instance, there are different synonyms of this condition. On the territory of the former Soviet Union, in some other countries, they mostly use the term rheumatism. In the whole world, they mostly use rheumatic disease or rheumatic diseases, like a group of diseases, or rheumatic disorder or disorders. So it's there are hundreds of variants of rheumatic diseases, and they could be defined as a systemic immune aseptic inflammatory diseases. So systemic affects all the body, all the organism, mostly connective tissue. Then immune, so immune related or immunity related. Aseptic, so at the moment of the development of these diseases, even if it is of their conditions by infection, but at the moment of their progression and development of progression, probably there are already no infection agents at all, I mean no infections, and inflammatory diseases, inflammatory nature of them. Good. And more specifically, about which we are going to discuss today, is named acute rheumatic fever. It's a certain nosologic form, a certain disease. Acute rheumatic fever, here is the coding according to International Coding of Diseases, M79.0. It's a systemic, again, immune, aseptic, inflammatory disease which develops as a deferred consequence of infection of group A streptococcal infection, and characterized by changes in connective tissue with predominant affection of four main aspects: heart, with mitral valve, as you can see on the slide, or aortic valve, or myocardium, or even epicardium. Okay, so with predominant affection of heart or joints, here is the typical illustration of this condition. Major joints, right? So it's like knee, elbows, so. Nervous system with chorea developments or some other affections we'll discuss today. Skin affection, mostly on the surface, right? And probably there could be the rest of variants, but these four are main. So remember, heart, joints, nervous system, and skin in this order. Mostly because the most important changes are related to heart, and then downgrading to up to the skin. The synonyms again of this condition are rheumatism or rheumatic disorder, or Sokolsky Buyo disease. Sokolsky Buyo disease you might have studied at your course of pathologic anatomy or pathomorphology. There could be different clinical forms of this condition, and if depending on what group of organs or what system of organs is affected most of all. If heart is most affected, it is carditis, right, or valve disease. If nervous system, Sydenham's chorea or chorea minor or Saint-Vitus-Dance may develop. So if in brief, if we generalize, the acute rheumatic fever is insidious, like it licks joints just kindly, while it's dangerous for heart. It bites the heart. This means that regardless of the fact that there are, let me illustrate, there are significant affection of joints, right? But there are no there are small, minor residual changes left to the joints. While in the heart, let me illustrate, there are very severe changes like um, disturbance of permeability of the course of blood there, or insufficiency vice versa, or affection of myocardium itself and development of heart failure and so on. So it bites the heart. Every time there is attack of acute rheumatic fever, some residual changes remain in the heart, and this is why it's very dangerous. The epidemiology of acute rheumatic fever is so that it has trends to affection of those regions where there are either low-income countries or unfavorable climate conditions, and it is much less distributed or much less insidious in the regions where there are good services, the good medical service or healthcare service, where there are better conditions in relation to climate and so on. The following aspects of epidemiology are specific, are typical for acute rheumatic fever. The age, the peak of prevalence of acute rheumatic fever is related to the uh, 5 to 20 years old period peoples. Very rare, no, much more rare, it develops in aged more than 30 years. About gender, the female contingent, the female population, undergoes the influence or development of this disease much more frequently than male. And in women, there mostly affection of nervous system appear in case of in form of chorea or in form of mitral stenosis. It's the heart problem, right? Endocarditis development. While in men, there is mostly aortic stenosis. This doesn't mean that no mitral stenosis is possible in men. Of course, it also develops, but there is such an inclination, such a tendency. The incidence of acute rheumatic fever all over the world is about 5 per 100,000 population. And annually, all over the world, about, just imagine this, 20 million new cases are diagnosed annually, each year. 20 million new cases. Rheumatic fever um, might be diagnosed in about 3% of untreated sore throats. Those people who have these symptoms from side of their throat, but they do not undergo the proper treatment at all. Especially, for instance, it's actual for our era of COVID pandemic, because COVID itself might even, if not having any residual changes or complications, but it might be accompanied or complicated by bacterial infection, including streptococcal infection, beta hemolytic streptococcal infection type A, and by this may severely predisposed to development of acute rheumatic fever in prognosis, some months. About 1/3 of these cases result from preceding infection. I mean, clinically significant, clinically prominent infection. And about 25 to 50% of all cardiac admissions are more or less conditioned by acute rheumatic fever. The predominant location or place of affection in case of acute rheumatic fever is mitral valve in form of mitral stenosis in about 99 and 8%. Let me remind some basics. We distinguish three types of hemolysis, bacterial amine hemolysis: alpha, beta, and gamma. And in the case of alpha hemolysis, it's partial. In gamma hemolysis, there is even no at all hemolysis. It's typical for Escherichia faecalis, for example, and beta hemolysis is complete and typical for Staphylococcus pyogenes or Streptococcus pyogenes. Good. So again, the most specifically, acute rheumatic fever is caused by preceding infection uh, caused by beta hemolytic Streptococcus of group A. Here is the illustration of its cultures. Plus, of course, there is some predisposition, some genetic predisposition. Those who are carriers of class 2 humoral histocoagulability complex antigens, it's DR2 in blacks and DR4 in whites. Of course, as we have already discussed with you, um, acute rheumatic fever and infection with beta hemolytic Streptococcus group A is conditioned by social factors, including most of all the level of the quality of medical service and conditions of living and so on. There is such a citation represented by one of the most well-known researchers, specialist in the field of acute rheumatic fever, James Rota, that rheumatiz will not disappear until beta hemolytic Streptococcus group A exists and circulates in nature. Okay, what's the motivation for dental students to learn this topic? If you remember, previously I have already introduced my understanding on the reasonability of the course of internal medicine for dental students, that there are at least three reasons. For one hand, many of conditions, emergency conditions, might develop at the time when stomatologist or dentist conducts his activity, and this might be the only one medical doctor who is available and may help the patient. So you should know the general principles of diagnosis and treatment of any or at least main urgent conditions. The second reason is, and for instance, in case of acute rheumatic fever, in some especially acute cases, they could be acute heart failure development or exacerbation or development of this acute heart failure on the background of preceding cardiac disease, including valve disease or so. And maybe some other conditions like anaphylaxis and some others. The second reason is so that in your work, in your specialty, rather often the changes in oral cavity are at least conditioned and as maximum caused by changes of the internal organs, some pathology of internal organs. And until your colleague, maybe generalist or some therapist or endocrinologist or GAT specialist or cardiologist and so on, treat the main disease, you will not succeed with your stomatological or dental treatment as well. At least it will not be so effective. And the third reason is so that, and for instance, the second reason is also applicable to acute rheumatic fever, because until the acute rheumatic fever is treated, or has been already treated, uh, and the circulation, disturbances of circulation are compensated, and a proper circulation in oral cavities supported, and maybe nervous system affection are also compensated, probably you will not succeed with the treatment in oral sphere. The third reason is so that some diseases of internal organs are conditioned vice versa by changes in oral cavity. And your, as dentist, role is probably one of the main in treatment of or diagnosis and treatment of some patients in order to succeed with disease of internal organs, so vice versa. And this is fully applicable to acute rheumatic fever as well, because chronic inflammatory diseases in the oral sphere might result in acute rheumatic fever. I hope you've got this idea. In order to illustrate some conditions, some diseases which may be related to the development of acute rheumatic fever by progression are here. For example, this chronic inflammatory condition might be located on the lips, on the mucous membrane of the oral cavity. Here is the illustration of the lips. On the palate, right? On the palate as well. So if this chronic inflammatory streptococcal infection or beta-hemolinic streptococcal infection type A persists in oral cavity, and dental or stomatological personnel does not care enough about it, this may result in development of acute rheumatic fever. While the main location, of course, are tonsilli, not oral cavity, but deeper. But they could be both options. Here is some more illustrations. Tonsillitis, right? Tonsillitis caused by beta-hemolinic streptococcal infection type A is the typical associated disease preceding acute rheumatic fever development. At least these persons are at high risk of this. But as you can see, the location of this streptococcal infection may be different, not only in the oral cavity or throat and so on. This could be on the nose, on the nasolabial region, on the face, other locations, one more, and even not in orofacial region at all. For example, on leg, as far as I see, right? On different locations. So the pathophysiology of this condition is complicated, so I advise you to download or to get this presentation. I've sent the link to the folder where this presentation is located, so you may download it and use. The main aspects of this pathophysiology of this disease are the group A beta-hemolytic streptococcus secretes substances which affect human cells. Some of these substances are represented on the slide. There are streptolysine O, streptolysine S, streptokinase, hyaluronidase, and M protein. Each of these substances plays their certain role in the development of the disease. And finally, you should take in mind that antigens which cover, let me show, which cover, that are located on the cellular membrane of this streptococcal bacteria have the similarity, structural similarity with those in the human organism, located on the surface of the cells of connective tissue. And when immunity reacts to the foreign bacteria and starts to produce antibodies and conduct this reaction, antigen antibody on the surface of the bacteria, simultaneously it damages the structures of own structures of the organism all over the body of the connective tissue, with predominant clinical manifestation from side of heart, joints, nervous system, and skin. While anyway, you should understand that all the variety of connective structures, connective tissue structures, are also affected simultaneously. Then, as a result of this immune system, of this production of anti-streptococcal antibodies, um, these antibodies have a reaction. Uh, they getting connected, right? Both to bacteria and to own structures, including heart tissues, again, joints, nervous system structures, skin, and so on. And this leads to autoimmunity development. So the main component, the main mechanism of acute rheumatic fever development is autoimmunity. If we simplify this algorithm, these steps, we may state that beta streptococcal infection leads to rheumatic fever, and as the progression, as the prolonged course of this condition, there is an option of chronic or rheumatic disease with residual changes of what we have discussed with you: heart, joints, nervous system, and skin. From point of view of pathomorphology, morphological aspect of this condition, this systemic inflammatory damage of connective tissue is manifested by the following histological lesions, right? Or it is staged, following stages of it. Primarily, there is mucoid and fibrinoid swelling. You have studied this on the pathomorphology, and maybe you remember the outlook of this swelling. Here is on the slide. Then development of granulomas. They are named by the researchers as a Shov-Talalayev granulomas. And finally, development of fibrosis and sclerosis. Right? It is growth of connective tissue on the place of preceding locations of this granuloma. Primarily, this growth of connective tissue is defensive. It's adaptive reaction of the organism, and it is aiming on surrounding of the foci of this inflammation, and by this eradication of it from the contact with the immunity. While this leads to so huge depositions of connective tissue, so significant remodeling of connective tissue structures, again in the organism, and in this case in the endocardium, right, with affection of valves as well, that this is related to significant changes of hemodynamics, and it is dangerous for the life of this patient because it leads to decompensation, to development of heart failure. The classification. Okay, let's make a short break, and I'll see how many students came, and we'll continue from this slide after the break. 10 minutes. Oh, I see some new students have joined us. Hello. Hello. I'm glad to see you. Thank you for your registrations. What questions have you got while we have discussed the basics of acute rheumatic fever? Maybe you have some ideas, maybe you have some practically applied questions I can help you with.
No, Doctor, there's no question.
Hmm? If anyone is late or will come later, let me, for instance, screenshot. Okay. I will upload this presentation, not this presentation, but our discussion today, or this lecture, I will upload to my personal YouTube channel, where you may get all the information and look through the lecture. More convenient way for you, probably. So in order to do this, it's I hope, I believe, it's enough just to put my name, Oleg Kalmykov, and probably it will. Yes, here it is. YouTube playlists. You'll see the other. There will be other, because I'm the owner of this YouTube channel. I have different interface, but you'll see something like this. Some vlogs, and in English vlog, there are all the lectures and everything I do for you. For example, our previous in myocardial infarction as well, and so on. Tell those who hasn't. Okay. What else? While we're having a break, let me remind and introduce again the concept of medical cluster. I would be happy you might join too. By medical cluster, I understand that this is a collaboration of professionals in field of medicine and medical and even non-medical organization. So now I'm in process of creation and adjusting of the work of this initiative of this project. The main idea, let me show, the main idea of this project is to unite those people who are involved in medical practice, and unite the medical organization all together. And here is the description of it in English, in Ukrainian and in English, of course. Our side is right, where we conduct our practical work and scientific researches and medical education and many other activities in support with each other in more efficient way. For example, we increase the efficiency of coordination of already existing medical organizations, private, communal, volunteer, academic. Let me show, for instance. Here are they. So medical businesses, I mean private hospitals, laboratories, diagnostic centers, rehabilitation centers, so-called non-private medical organizations, municipal, departmental, or governmental, non-profit organizations, and volunteer groups and charity funds, right? Foundations. Then academic. Here we are now. I'm professor of one of medical universities, and we make collaboration with other universities and medical faculties as well in field of education and medical education, medical science, and others like those organizations which are proficient in management, in legal support, in safety, information technologies, work with personnel, logistics, production of medical services and goods and their quality control, communications, marketing and PR, funding, and so on. So we help each other in this relation and make partnership with local communities on regional, city, or village levels, and with foreign partners, with foundations, medical organizations, hospitals again, medical centers, and so on, academic structure, academic organizations like universities, communities, and others, and they help us. They simply condition the most efficient ways how we can act. And here is the illustration about the reason we do this. Because each of these types of organizations have their opportunities and limitations. For example, medical businesses are full of ambitions. Typically, they are well equipped, they have good premises, then they have the professionalism of their medical personnel is high, while international relations or the quantity of medical personnel is not so at the high level because they simply do not have such experience, right? And usually, medical businesses are always they always starve for clients, right? For beneficiaries. While in non-private organizations, they are full of clients, they're full of beneficiaries. They have good medical professionalism, while they are limited in premises, while they are limited in international relations, and they could be at some middle level in ambitions, in medical supplies, equipment, and in medical personnel quantity, I mean. In academic organizations like medical universities or medical faculties of universities, they have good international relations, undoubtedly, of course, and the personnel who works there is motivated and they are highly professional. In average, of course, there could be some exclusions. While ambitions and premises and medical personnel quantity might be not so developed, right? And medical supplies and equipment and beneficiaries quantity, it depends, of course, but in average, there are not so many people there. And in non-profit organizations, they have very big ambitions and much of beneficiaries, while the rest is not so well developed. In the majority of cases, non-profit organizations, of course, if they are not medical, they are not non-professionals in medical field at all. So what actually do we do in this cluster, and what is your possible role as a medical students or further young specialists, young doctors? You may act as volunteers, you may work as experts, right? As experts already, right? Because you are experienced, or we have one special options as assistants. You may already work as an assistant even while you are at the stage of your student studying, right? And we have one more option for English-speaking medics. We widely invite English-speaking medics in fundraising for this project. And your benefits, your salary and everything you get from the funds you fundraise. From our side, we conduct education in fundraising, in special medical fundraising. Let me show. Here it is. It's my publication on my Facebook. So it could be either volunteering free of charge, or we can pay salary for this. And here are some links where we study, and we already have developed, or at least let us name it, we are developing our own educational cluster. It's still still mostly in Russian, but in some time we'll prepare English version of it. Maybe it's not comfortable for you to read this in Russian, but in general, there are different courses for even non-medics, for medical students, plenty of them, right? Then in medical practitioners, for medical practitioners in different fields, for those who are interested in medical, again, science, and even those postdoctorate, right? Postdoc stage for those who are managers or they are leaders in medical researchers, for owners of medical business, for investors in medical projects, for even governmental programs. So let's come back. Now we have to continue with our lecture. So in general, we increase the efficiency of everything we have discussed with you: medical practice, medical education, medical science, and the organization of medical care, right? Medical business or non-profit. We provide local conditions for this development. We attract international aid. We improve the quality of medical care and develop further projects in this field. And what is most, what encourages me to work in this project, most of all, this technology, this methodology is maybe easily transferred to any other location inside the country or in any other countries. So I'm eager to develop it locally and then transfer and scale to all over the world. So if you are interested in such collaboration, you are kindly welcome. While we are coming back to our lecture now. For instance, before we continue, let me see. Have you got any questions in this project in medical cluster?
No,
No, doctor. Thank you.
Okay, okay. You're kindly welcome if any. Good. Let's continue with acute rheumatic fever. By classification, here is the author of classification, Professor Nesterov. Acute rheumatic fever is distinguished by phase: active, and there is a decomposition of its first, second, and third activity degrees, or inactive phase. By active phase, we understand, later we'll discuss it, that there is active acute inflammation, development of the disease, progression of it, and so on, while inactive is the phase when there is mostly residual, there are mostly residual changes remaining. By other approach to classification, by predominant organ affection, cardiac or non-cardiac. While cardiac is also decomposited, maybe differentiated into primary carditis without valve damage, or recurrent carditis. By carditis, let me remind, we understand that there is inflammatory affection of heart with valve damage, while they could be affection of only myocardium and without endocardium affection. But if valve endocardium is affected, there is other scenario. Then fever without carditis at all, it's the best chance, the best variant. And then myocardial sclerosis, valve insufficiency development. Oh, unfortunately, we have a Syrian now, their alarm regarding the possible attack. I hope no rocket will fly to me now while I'm delivering the lecture. Good. I hope you are in you are not at the danger, right, of attack at the moment. Can we continue with the lecture?
Yes, yes.
Okay, okay. And the non-cardiac variants of acute rheumatic fever may be related to polyarthritis, affection of many joints simultaneously, may be related to serositis in form of pleuritis, peritonitis, and some other. In form of affection of nervous system, chorea, or encephalitis, or cerebral vasculitis. What do you understand by vasculitis? Affection of small vessels in brain, which supply heart to brain. Pardon, so many alarms from all the sides. Then systemic vasculitis all over the organism, development of nephritis, or complication with pneumonia, dermatosis, or maybe some residual changes or outcomes, consequences of above-mentioned pathology. Then, the third approach to classification is related to different types of courses. Just one moment. Sorry, because of this alarm. Just one moment. Just few. Okay. Pardon for these discrepancies. Um, my course, by course, yeah, they could be acute, subacute, long-lasting, and continuously recurrent, and latent. Latent with no clinical manifestation or very no non-specific probably. Then the fourth approach to classification is by heart failure development and its severity, where there could be no heart failure at all. There could be heart failure first stage or second stage, second A or second B, or heart failure of third stage. Again, by phase, acute, it's acute rheumatic fever. By or chronic, there could be chronic rheumatic heart disease. By activity, active or inactive. By clinical manifestation, carditis as main, or possibly arthritis or Sydenham's chorea or erythema marginatum. It's affection of skin in form of erythema or subcutaneous nodules development. By complications with presence or absence of heart valve deformities. And the next approach is by presence and severity of heart failure, with including evaluation of stage and functional class of it. The clinical manifestation of acute rheumatic fever is the following. The onset develops in 1 to 3 weeks after preceding streptococcal infection. And therefore, a good idea is to check for possible streptococcal nature or presence of streptococcal infection after or in 3 to 4 weeks after the onset of some sore throat symptoms, even if you are definitely sure that it is COVID or non-COVID viral infection related, because streptococcal infection may follow the viral one. The complaints typically includes fever, weakness, fatigue, sweating, anorexia, weight loss, or something like that. Non-specific at all, as you can see. The basic signs by which we medical doctors might suppose that there is something related to this condition are related to carditis, polyarthritis, chorea development or Sydenham's chorea, or skin affected. Skin affection in form of erythema marginatum or subcutaneous nodules. On this lower right part of the slides, you might see some illustrations, which typically represent the main aspects or main criteria of acute rheumatic fever. It's fever directly, pericarditis with appropriate rubbing sound on the auscultation, myocarditis with appropriate, again, auscultation changes and disturbances of propulsation, I mean the cardiac output, decrease of it. valvulitis with appropriate gargles, right? Sounds, murmurs, which may be also auscultated. Then they could be vegetations on the edges of valves, which you may reveal by ultrasound, for example. Then by laboratory tests, you may reveal high value of erythrocyte cementation rate, then hemolytic activity of the cultures you take from the throat or from the locations of this streptococcal infection. And arthritis and arthralgias may develop and in the enlargement, right, of these of the joints, major joints. Then there could be clinical manifestation related to nervous system affection as well, in form of Sydenham scoria. And if taken, if the biopsy is taken, there could be a histochemical evaluation of a Schoff alive nodules or granulomes there. These are main diagnostic criteria. The intensity or severity of different clinical manifestations from side of heart, joints, skin, nervous system, and so on, typically differs. Primarily, there is mostly manifestation from side of joints. If you remember at the beginning of this lecture, I even mentioned that rheumatism leaks the joints, but hurts or bites the heart. So joints react, they enlarge, they are painful, so they cause many symptoms, while they are not, they decrease in the intensity in just 1 or 2 months. For carditis, its intensity increases more gradually and decreases also gradually, but it lasts for more prolonged time, and what is most important, there are always some residual changes remaining. From side of nervous system, it takes several months until it develops so that it will be clinically significant. So you doctors will reveal this, or maybe patient will complain on it. While erythema marginatum may develop simultaneously with joints affection and heart affection, and subcutaneous nodules formation is delayed for 2.5 or 3 months or so. Then there are two main patterns of the beginning of the onset of acute rheumatic fever. Sudden, with polyarthritis for about 2 months after preceding streptococcal infection, with fever and intoxication, endogenic intoxication, and so on, or insidious, subclinical, with mild carditis, with not so prominent medical clinical manifestations. And types of onset are also associated with the age of the person, of the patient. The younger is the patient, the more expressed is carditis, affection of heart. The older is or she, more prominent is affection of joints in form of arthritis. Here are some illustrations of what happens with the organs on the background of acute rheumatic fever. You may see that in the heart affected by carditis, especially if it is pancarditis. There could be endocarditis, myocarditis, and pericarditis, or epicarditis even. And if all structures are affected, we name this condition as pancarditis. Pan means all in Greek or in Latin. Then, here is the illustration. So the heart is enlarged, it's hyperemic, and sometimes as a consequence of pericarditis and intensive formation of connective tissue structures, they could be developed of so-called wireless heart. It's such a symptom named wireless because it is like covered with wire, like hair or hairy heart. The physical signs of carditis include new murmurs. What do we understand by new? Previously, there could be some sounds from side of heart on this patient by some other reasons, while some new murmurs appear, or some old murmurs change in their character. Then there could be tachycardia inadequate to fever level. So tachycardia much more expressed than its reasonable in such a fever. Why it is so? Because of development of inflammation of heart and its affection. Heart tries to contract more rapidly to support the appropriate cardiac output, but maybe sometimes it even fails. Then there could be cardiomegaly. You may understand that this develops by mostly percussion or ultrasound investigation, or if you experience it enough by auscultation as well. Arrhythmias development and the disturbance of conduction inside the heart with gallop rhythm. Why it develops? Because of inflammation of the structures of heart, myocardium, and conduction structures for this contraction. There is disturbance of conduction, and there could be discoordination of contraction of different cameras of the heart, both any of them, right? Then next symptom sign, pericardial rubbing, because of the development of inflammation on the surface of pericardium and the formation of disturbance of serous liquids production. There could be rubbing of these leaves of pericardium with appropriate sound we might perceive by auscultation. And further development of heart failure and its severe forms, intensification of them, progression of heart failure. The acute phase subsides the following aspects. Fibrosis alters leaflet and cusp structure. This results in leaflet or cuspal thickening along valvular margins or of closure, right? When in the places of these valves have margins. Then valves are affected. Most often the mitral valve, while there is an option of other as well, like mitral and aortic simultaneously, and most rarely there could be a lone affection of aortic valve without any other. As a result of this affection, so first mitral valve is affected, secondary valve, mitral valve and aortic, and thirdly only aortic, right? The incidence of mitral valve affection is about 60 to 75%. Aortic is about 25%. Tricuspid about 10%, and in 10 to 40% of adults, residual progressive valve disease remains for all the rest of life. Here is the schemes of where these vegetations of newly formed connective tissue are located. You may see that they are on the margins, on the edges of cuspids, right, on the valves, in the place of connection between chordae and valve as well. So this at the very beginning, fibrin gets sedimented on the edges of the valves, on the lines of closure, and then these fibrin depositions transform into the scar. And they could be either adherence and scarring or scar contractions, right? In first case, there is chronic stenosis development, and or in second variant, there could be chronic regurgitation and so-called insufficiency of this valve. Then the fusion of chordae might also develop, thickening of cusps, and therefore formation of stenosis of mitral valve. Here is the illustration of such condition. You may see the vegetations. Here is, I show you by the mouth pointer mouse pointer. Good. The chronic rheumatic heart disease leads to development of mitral stenosis and requires valve replacement rather often. And it may lead to pancarditis, affection of all the structures of hearts. So let's focus on mitral valve affection. What happens in this condition? First of all, here is the outlook of the typical mitral valve affected by mitral stenosis. It is even named as fish mouth. It looks like a mouth of a fish. And here is the other illustration. There could be also, as you can see, formation of vegetation of on the edges and contraction, right? Stenosis. As soon as mitral orifice becomes smaller in case of stenosis, there are two consequences of this. In order to maintain left ventricle filling across the narrowed valve, the pressure in left atrium increases and blood flow across the mitral valve is decreased, which decrease finally the cardiac output. And this results in different effects from side of heart, from side of lungs, and other structures. For example, left atrium compensatory hypertrophies dilates due to increased pressure, and they could be atrial fibrillation and mural thrombosis even development. In turn, left ventricle is more or less protected by stenotic mitral valve, so it doesn't undergo any hypertrophy or dilation, and remains normal in size and contour. Next, the pulmonary arterial pressure increases. The intimal and medial hypertrophy of pulmonary arteries develop in order to, again, pulmonary vascular resistance, not in order, but consequently, the pulmonary vascular resistance increases, and this one more, in turn, increases the the requirements to the heart contraction. Right ventricle dilates because of the pressure overload, and pulmonary artery dilates, and this leads to pulmonary valve regurgitation, backwards stream of blood from pulmonary artery backward. This leads to tricuspid regurgitation due to dilated right ventricle, and right atrium also dilates due to volume overload, and right heart failure occurs. Here is the summarization of what happens in case of mitral stenosis on this slide. Again, mitral stenosis develops, left atrial pressure increases, left atrium enlarges, pulmonary arterial hypertension develops, left ventricle pulmonary valve regurgitation increases, right ventricle enlarges, pulmonic regurgitation again develops, and tricuspid annulus dilates, tricuspid insufficiency develops, and there is development of right ventricle failure. These may be manifested by dyspnea, by edema of lungs, by enlargement of liver and spleen as well, because of depositions of blood there because of the heart failure, right ventricle heart failure. Then, what happens with lungs? Because of pulmonary artery hypertension develops, primarily it's passively, and then due to muscular hypertrophy and hyperplasia, there is increased pulmonary vascular resistance. Just because there is thickening of vascular walls, and the stroma of lungs also undergoes changes. Then chronic edema of alveolar walls results in fibrosis. It's compensatory primarily, but it results in disturbance of breathing, right? And pulmonary hemorrhage and hemosiderine depositions in lungs develop with probable further pulmonary ossification and so on. From side of other sides, other aspects, other regions maybe of the organism, there is increase of venous pressure, portal hypertension and hepatomegaly, as I have already mentioned. They could be peripheral edemas and so on. Next, let me check time. Okay. The next type of affection of heart and valves of heart in case of acute rheumatic fever is affection of aortic valve. Here are the illustrations. There are hemisphere, right? Aortic valves normally, and in case of acute rheumatic fever. You may see how deformed they become, and they could be. This leads to scarring and retraction of leaflets. This insufficiency or regurgitation results from failure of a valve to close completely, and just leaflets simply do not close completely. Then, and appropriate changes develop as we have discussed with you, but with involvement of left ventricle primarily, as opposite to what we had in mitral stenosis. Arthritis is also a feature of acute rheumatic fever, and they could be following peculiarities of this condition in persons with acute rheumatic fever. Fleeting migratory polyarthritis involving major joints, mostly knees and elbows, or maybe ankles sometimes, so wrist. Then, this condition, I mean arthritis, occurs in about 80%, and involved joints are exquisitely tender. They're painful so much. In persons aged more than 5 years, arthritis is usually mild, but carditis dominates. And arthritis usually doesn't progress to chronic disease, as opposite to we had with carditis, right? Which progresses into valvular rheumatic disease. Here are some illustrations of typical affections of joints in case of acute rheumatic fever. As you can see, the main major elbows locations, elbows or knees, and so on. And you may see how enlarged they become, how affected, and it's painful, and so on. But anyway, in few months, they mostly recover. Of course, in case of proper treatment. Nervous system affection. In case of nervous system affection, typically, there is some problem, technical problem. Let me show you by other way. Let me show how it is manifested. Will get opened, I hope. Yeah. Try again. You may see how this spontaneous, you may see the attack of chorea in this child. All these movements are spontaneous. These people cannot control them. The onset of this attack of chorea may be just associated with maybe some mental stress episode, just episode. While while the mechanism of this condition, you may see it progresses. You see it starts to involve not only hands but legs as well. Some mimics sometimes. Now mostly legs. It tries. This child is asked to make a movement, and on the effort to do this exercise, he has problems with coordination, and spontaneous movements start to appear. Pay attention to his face as well. There are also, and sometimes even involvement of the trunk muscles, maybe. Here is the typical. Okay. Here is the typically how it is manifested. So the synonyms of this condition is Saint Vitus dance or Saint Johannes chorea or chorea minor or rheumatic chorea. It occurs in about up to 10% of cases, if you remember, mostly in women, mainly in girls, right, of 1 to 15 years old. May appear even 6 months after the attack of rheumatic fever. Just imagine, they could be onset with the joints affection and heart and skin, and in 2 or 3 months they degraded, become not so expressed, and nervous system affection appear and progresses. Then, clinically, this condition manifests as abrupt, purposeless, non-rhythmic, involuntary movements, as I showed you in the video, with deterioration of handwriting, of course, with emotional lability, with grimacing, and so on. And clinical signs include pronator sign, jack-in-the-box sign, and so on. You have seen the video already. Then, the next type of affections in case of acute rheumatic fever is skin affection. It develops in less than 5% of all the persons in form of erythema marginatum. It's solitary transient lesions of 3 to 5 centimeters in size. Here is on the slides, on the photos, you may observe them, with a pale center and red irregular margin. These formations more appear on trunk and limbs, and they are not itchy at all. These conditions worsen with application of heat or under the influence of sun, and it's often associated with chronic carditis. Chronic carditis develops, and this erythema marginatum, if any, may be absent at all. Carditis is much more frequent. You may see some more illustrations about the dynamics, about the course of this affection of skin. One more illustration. You see such a field affected with erythema marginatum. And one more. Other type of skin affection is subcutaneous nodules. They appear in up to 10% of the patients. These nodules are totally painless, pea-sized, palpable under the skin, and they mainly situated over extensor surfaces of joints here on spine or scapular or scalp even, and they may be associated with strong seropositivity. By seropositivity, understand that later we'll discuss today with increased laboratory markers which we um, get from blood serum. And these nodules always are associated with severe carditis. So if you observe this formation, you should be aware about severe affection of heart as well. Here is one more illustration of the location of it. The other forms of acute rheumatic fever include polycerositis. It's extremely seldom, like pleuritis, peritonitis, pericarditis, and so on. It could also get manifested by vasculitis affection of vessels all over the human body, or in some locations in brain, for example, and others, in lungs, in kidneys. The diagnosis of acute rheumatic fever, a part of evaluation of clinical signs, include laboratory tests. The complete blood count or general blood test shows leukocytosis with neutrophilia, raised erythrocyte sedimentation rate, increase of C-reactive protein level, and more specifically, increased levels of anti-streptococcus antibodies, SLO. They could be optionally changes in electrocardiography as well, in form of arrhythmias with sinus bradycardia or tachycardia, or bradycardia, or extrasystolia or atrial fibrillation. They could be blockades of nervous impulse conduction across the heart with it's the minor diagnostic criteria. On the ultrasound investigation of hearts, which is one of widely used in this condition, there are signs of carditis, condensing, thickening. They could be valvular abnormalities with regional thickening of valvulae, or with regurgitation, which you may get from echocardiography with Doppler. In case of mitral stenosis, there is usually normal or slightly enlarged heart. If you remember, we have discussed with you earlier today that in mitral stenosis, left ventricle is so-called defended from the overloading. It even the load of it is even gets decreased. The enlarged atria do not produce cardiac enlargement so much as left ventricle enlargement could. and while enlarged ventricles can do, and strengthening of left heart border or convexity along the left heart border due to enlarged atrial appendage. You may see on the X-ray that there are appropriate signs of enlargement. Right side, left upper side, because of affection of appropriate structures, but not left ventricle, right? Here is the convexity from enlarged left atrial appendage. And here is the sign of enlarged pulmonary artery segment from severe pulmonary artery hypertension, and straightening of left heart border from enlargement of left lung artery, left atrium. Small aorta from decreased cardiac output on X-ray, and double density again on X-ray. Okay. Upper lobe vessels equal or larger than the sizes of lower lobe vessels. This X-ray symptom is named cephalization. Then we conduct the test, the so-called throat culture test. Both tonsils and posterior pharynx, they are almost always positive, with group A beta hemolytic streptococcus seeded from the throat, and but this test doesn't differentiate carrier of infection with the person who is infected. Actually, as soon as during our everyday life we contact with the sources of infection, some portion of it may be sedimented on the surface of our mucous membrane, but presence of this infection doesn't mean that this bacteria, I mean in this case, doesn't mean that infection develops in the body. So this test doesn't differentiate these two conditions. Then the next approach, laboratory approach, is antigen detection with a high sensitivity but low specificity. This test cannot differentiate carrier from infected person, same as throat culture, and this test becomes positive in about 90% of patients with acute rheumatic fever. And this test may be useful for identifying patients who are at risk for developing of rheumatic fever. The antibody detection in the blood serum, the rising titer only confirms a recent infection. It doesn't prove the rheumatism or acute rheumatic fever by themselves. This test cannot differentiate infected person with carrier. Then, antistreptolizine persists for several weeks and falls first, and anti-desoxyribonucleic acids remains high for several months. The diagnosis of acute rheumatic fever includes clinical diagnosis, the clinical manifestation. You should take in mind that no single diagnostic sign or specific laboratory test available for diagnosis, and diagnosis is based on so-called modified Jones criteria. What are they? The revised version of Jones criteria for diagnosis of rheumatic fever. For instance, I advise you to have this slide or this table with you when you will continue to learn this topic, study this aspect. So they include major manifestation includes carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules, 5 of them, and group of minor manifestations. Clinical, it's previous rheumatic fever or cardiac heart disease, arthralgia, fever, and laboratory manifestations, acute phase reactance increase, erythrocyte sedimentation rate, C-reactive protein, leukocytosis, and some other like prolonged PR interval on electrocardiography and so on. And other approaches with supporting evidence of streptococcal infection are related to increased titer of anti-streptococcal antibodies, anti-streptolizine O, and other like positive throat culture for group A streptococcus, recent scarlet fever, and so on. And the principles of diagnosis include they could be the high index of clinical suspicion and evidence of previous streptococcal infection plus either two major Jones criteria or one major and two minor Jones criteria. So at least one major should be present with two minor, or two major is enough to prove the diagnosis. The differential diagnosis of acute rheumatic fever should be conducted with infective endocarditis, because it also leads to development of valve affection and so on. With autoimmune connective tissue diseases, if you remember, there are hundreds of different rheumatic diseases, but this doesn't mean acute rheumatic fever. There could be other ones. With systemic lupus erythematosus, with juvenile rheumatoid arthritis in terms of skin affection and joints affection appropriately, with reactive arthritis, with serious disease, with measles, with sarcoidosis, with hemorrhagic vasculitis, and other similar conditions. Even with acute heart failure or chronic heart failure conditioned by other situations, other diseases, it might be also should be also differentiated. So the next part of the lecture was supposed to be dedicated to treatment of acute rheumatic fever, but it's rather big. I advise you to get access to this presentation or to other sources of information, and you'll look through it. There are everything is arranged into tables and described very thoroughly for you, but it takes much more time that is left for our today's lecture. So let me finish the my parts of this lecture delivering. Here are some of my contacts as well. You're welcome to contact. For instance, I'll change them because they have already went some changes. Tell me please, dear colleague, dear students, what questions do you have now in relation to the matter, to the topic of our today's class, to our today's lecture? Dear students, are you there?
No questions. Yes, we.
No questions, right?
Yes.
Yes, doctor. Thank you.
Okay, so keep healthy. See you later. Good luck.
Goodbye, doctor. Thank you.
Thank you.